Start recording. Let's see. Okay, so liver transplants. You know what? The last thing on my mind today will be the first thing I talk about, just because I couldn't find a single image to really show what I mean. And if I don't say it now, I'll forget. When we do a liver transplant ultrasound, sometimes it is the next day or later that day. You're already doing you're already doing ultrasound because they want to know obviously right away, is those vascular anastomoses, did they take? Is there internal bleeding? Is there a really bad stenosis? Is there already a thrombus? That kind of stuff. But this is major surgery, and there's been plenty of time where I go and do whether it's one of these or something else post-op, and they say, okay, do a full abdomen or do a liver transplant, and you have about that much room on the entire abdomen that's not covered in bandages. Or a lot of times they'll leave wounds wide open and pack them, and perhaps even have a pump if there's an abscess. And so you have all this stuff. You got to be, obviously you don't want to introduce bacteria into there, so you'll use a sterile gel and sterile technique as much as you can as an ultrasound tech. I mean, they're out of surgery. They're not supposed to become infected, but we still have to take some precautions. So a lot of times this entire exam is done coronally, kind of through the right costal area. And it can be pretty tricky to do an entire exam from one little window, but it can be done because, in other words, let's see, if I were to draw a little transducer here, I would put the let's put over here, transducer like over here on the side of the body, looking in through the side. But when you look from this direction, you can look straight down the barrel of the main portal vein and the renal, the hepatic artery. But yeah. So why do people get transplants? Well, obviously their liver has failed. So that could be long-term chronic hepatitis C, ETOH, or alcohol abuse. By the way, they're usually at the bottom of the list, or at least they find themselves at the bottom of the list if they ever get tested and they're found to be drinking alcohol again. So I'm sorry, I shrunk this so it's a little digitalized here, but cirrhosis for really any reason. So obviously Hep C long-term can cause cirrhosis, but idiopathic cirrhosis, biliary cirrhosis, hemochromatosis and Wilson's disease down here, these can cause cirrhosis in the long term. Autoimmune hepatitis, up here, primary sclerosing cholangitis. So that is an inflammatory reaction of all the bile ducts, and if you inflame and end up closing off the bile ducts, your liver is going to die. And if Budd-Chiari, the hepatic veins, if they become thrombosed, you get Budd-Chiari and your liver will die. In that case, let's see, any kind of acute liver failure, and HCC, hepatocellular carcinoma, if it's caught early enough. So, and sometimes we do catch it early, but oftentimes not. And so by the time hepatocellular carcinoma spreads, then it is too late. You are no longer on the liver transplant list. So And golly, how many, where did I write down? I guess they're right over here. So they get to the top of the list, they get some surgery, lucky them. And orthotopic, so an orthotopic liver transplant, OLT, is orthotopic just simply means that you're taking the transplant, whatever kind of transplant it is, and you're putting it in its normal position. So, you know, you're taking the liver out and you're putting another liver in the same spot. Orthotopic. I guess it's ectopic if you, like for a kidney, when you put it in the pelvis. Yeah, I assume it'd be called an ectopic renal transplant. But in any case, LD stands for living donor. There's not a ton of living donors. There's been I think in 30 years, 6,000 living donors, whereas in 30 years, the dead donors are the majority. That's about 150,000 people or transplants have occurred. So with a living donor, obviously you're not going to remove the whole thing. Otherwise, it wouldn't be a living donor anymore. It'd be a dead donor. Usually the right lobe is removed because that's just the easiest one for the doctors. They don't do it for any other reason other than for their, well, obviously it's easy for them, then it's good for you and good for the recipient as well as donor and recipient. Dead donors, we used to call them cadavers. I don't know where this dead donor, when that started, but DD stands for dead donor. That's the vast majority of transplants. And, you know, unfortunately with these, just like with kidneys, the longer that patient, or longer that liver is outside of the body, the more damage it's going to have. So they don't do quite as well. Although livers are very resilient organs. So, and that's the nice thing, but you could have half your liver removed and remember the term compensatory hypertrophy. Let's write that one down. That's just an awesome. Compensatory hypertrophy, yeah. Compensatory hypertrophy, that means that the remaining left lobe and caudate lobe will grow considerably to the point where you almost, as a donor, your liver volume could almost go back to normal, just from hypertrophy. So dead donors are the majority. You remove the liver and the biliary and the arteries and the veins, including the, that says IVC, whoops, including the IVC. Sometimes two people will get the dead donor's liver, and so obviously they have to split. One person gets the gallbladder, the other one does not, but one person gets the right lobe, the other person gets the left. Now, there's a few ways of doing that, and this is where it becomes challenging for us. Remember, especially the mesenteric artery, like the hepatic artery, doesn't always come off where it's supposed to come off. And that makes a difference in surgery, and that makes a difference in how we look at this as well. And depending on whether it's a live donor, whether you get a full liver, dead donors, there are little differences in each one. And that could leave us very confused. It is always a good idea to look at everything. Talk to the doctor, go to your radiologist and have he or she help you understand what they expect to find. And they could read the report, they could look at previous CTs. So, you know, if there's a CT, look at that. Previous ultrasounds, look at those reports. It is always important to do all of this, but man, when it comes to transplants and any kind of anything where they've changed the vascular nature of the body, it is always a good idea to look at previous reports and examinations. I mean, MRI is a possibility, but unlikely. So let's see. Yeah, we'll just look at this guy first. Let's see. I think I need to back up a little bit. Make sure that's as small as possible. Okay, so well, we got hepatic artery, of course. What I've done here is create little stitch marks going across. So this is recipient, there, there, and there. In other words, everything else over here, well, let's go ahead and put donor. So in this case, we know just from the stitch marks how this was done. This had to be a dead donor, because not only have we taken the entire liver, but we've taken, well, a section of IVC from there all the way down to there. That's all donor IVC, and this is recipient here. I call this the standard. The book says that this is the most common, but then they're also saying that this other one's becoming more common. But in any case, dead donor, they basically remove the recipient's liver. They cut the hepatic artery, portal, let's do main, portal vein, and then let's do CBD, and common bile duct. They cut all these, remove everything you see here, cut the IVC. Obviously, they got to work quickly, and they clamp it. So I mean, obviously, you don't want, they're not going to bleed out because everything is clamped. Out of the donor, they now place a new liver, a donor liver, with a hepatic artery sticking out of it. And if there's anything going on, if this donor had two separate hepatic arteries, that's important to know. They're going to have to do two separate anastomoses to the recipient. So something like that could occur. The main portal vein and the common bile duct has been cut as well. So all these are placed, and the anastomoses are, let's see, end to end anastomosis of all vessels and duct. Another possibility is, and it's just amazing how our plumbing works, and according to your book, this is becoming more popular. You know, I've just kind of drawn the, the liver here with the hepatic veins, obviously, right, middle, and left hepatic vein, and then a small portion of IVC. And when I say IVC, I mean donor IVC, just that little piece right there, and this is all recipient here. Perhaps I could have done that more like down here, but well, in any case, this is fine. So in this case, rather than cut the IVC and do an end to end, what we have here, right there with the IVC, would be either an end to side, which is kind of what I've drawn here and kind of what was in your book. But the picture down here, and actually what I've seen, this is more of a, where do I write that? Like my little cheater here. A side to side anastomosis. So in other words, they put two vessels, they've sliced them on the side, opened them up, and sewed them together side by side. Now, on what we're seeing down here is a very short segment of IVC. So they've, let's see, they've sewn off, sutured that end, sutured that end, sliced the side of it open, sliced the side of the recipient open, and then sewed these together. So that's a side-by-side piggyback. So that's another possibility. So when you go in and look, and you see something that looks like that, you say, oh, okay, a side-by-side or some kind of piggyback. Whereas this, if really well done, you might not even know. You might not even know it was a transplant at all, because you're not going to see these stitches. You're not going to see any of these stitches, and then everything was put together like it's supposed to be, and it's, liver's tacked in place. How would you know? So your book also mentions if, however, the recipient's common bile duct is damaged, deformed, whatever, then a Rowan Y procedure is performed. A Rowan Y procedure. And this won't make too much of a difference to us. We should know about it, but we're not going to see. Look, the part of this procedure is, well, obviously you can see down here, it's cutting up intestines and reestablishing connections there. We don't see these connections in the first place that well. With the Rowan Y procedure, we still have to look at the hepatic artery, the main portal vein. We're going to look at the common bile duct, and if it's small, we're going to have a hard time seeing it, because it's not going to be in the right place, by the way. It's no longer going to be in the right place, so good luck finding it unless it's somewhat dilated. But the reason they do this, well, we already mentioned, is that we have a common bile duct that is damaged. In other words, we go back to this one, we got a common bile duct that just isn't going to work for us. And now you can't reach it all the way through down to the duodenum through the ampulla, vater, and how it's supposed to be. Instead, they have to find a new place to put it. And why they don't just go and stick it directly into the S loop of the duodenum, because we know this is obviously a little blown apart here. We know the S loop of the duodenum comes right up to here anyway. Why they don't just sew it in right there is beyond me, but they don't. They use this procedure. Now, this procedure is not exactly how they do this, but it's very close. It's how they do it with gastric bypass. Except with the gastric bypass, you don't leave you basically cut the stomach out. You might do something like that, where you cut off the big part of the stomach and leave this down here. That's one possibility. It's the Rowan Y procedure, is gastric bypass. But in any case, the reason they do that is because now food is going to travel down and really get into the jejunum it goes through the stomach, through the duodenum, and they make the cut actually in the jejunum. And then the food still goes into the jejunum, so that we're actually missing very little of the intestines. But now we have a connection of the bile duct into the intestines, so the bile comes down and is able to meet the food products of food, and then digestion after that occurs normally. Seems like overkill to me. I think doctors just like doing that stuff. Wow, I got to slow down. We are definitely going to have a short day today. Oh my God. That's all right. We have nice PowerPoint. Talk about that. Some other stuff too. So doctors do their thing. We come in and you know what I didn't write down? Let's do it right here. Our first exam, like I said before at the very beginning, is usually like first exam and within day. So you are scanning a patient practically fresh out of surgery. And the first thing you're going to do is you're going to open up your grayscale imaging, and your liver should look like dun, 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 a liver. It might be a little swollen. If it's swollen, it might be a little bit hypoechoic. But other than that, it should look like a regular liver. There shouldn't be any hypoechoic fluid collections or anything going on there. When we do, especially really post-op, some perihepatic fluid, in other words, some ascites, is okay. I mean, the person just had major surgery. Probably a little bit of blood serum, maybe even just a little bit of blood left over. Now, actually, it shouldn't be blood, but blood serum, any kind of all that inflammation from all that surgery is going to leave a little bit of fluid behind. So that is okay, as long as it's a little bit. But we're also going to look for evidence of a hematoma. So basically bruising of the liver or internal bleeding on the liver. We don't want to see that. Hemoperitoneum, in other words, blood ascites. So if it's more than just a little bit of ascites, we get concerned. And of course, you're going to report it, whether you find 2 cc's of ascites or 100 cc's or a liter of ascites. You're always going to report it anyway. A biloma, in other words, that's bile, really. So that might be near a gallbladder or near a common bile duct where the anastomosis was created. Is there a biloma there? And you might not recognize it as a biloma, but you at least found the fluid, so you can report it. A bile obstruction, so if the bile ducts are way too large, there might just simply be a kink or a poor suture job was done. Sometimes it's the doctors. Sometimes it's the doctors. They do the best they can, but the body is fighting them. Cholangitis can be precipitated by a liver transplant. Remember, that is biliary inflammation, and so and kind of cholangitis. So when you see periportal cuffing, that's a good word. Periportal cuffing, and that's like thickening of the periportal walls and biliary inflammation. So that is good to look at, or good to find anyway. Indications of infection, so any kind of necrosis, any kind of, I'm sorry, this is all one word, all one sentence. Indications of infection, necrosis, acute hepatitis. Remember, hepatitis isn't always viral, it just could just be an angry liver. And then also we're going to try to find any pseudoaneurysms. Yeah, granted, that's not really grayscale, but it kind of is. So you have an artery coming in, could be a very tiny artery, and during a biopsy, and sometimes the doctors within a few days after a transplant, they will biopsy the liver because they can look at a microscopic level to see what's going on. And if that biopsy needle goes through a artery, then pseudoaneurysm can occur. And of course, we'll have swirling blood inside of there. Wow. Yeah, this is going to be the shortest day you guys have had yet. Crap. Did not mean for that to be this short. I just can't believe how fast I'm going through this. I should probably look at the book and see what we're missing. Okay, so once you've done your grayscale, you're looking for any kind of fluid collections, hematomas, evidence of anything that doesn't look like a normal, happy-looking liver. We're now going to look at the Doppler. This will take a little more. This is the whole point, right? This is the Doppler. Well, first thing we could look at, it really doesn't matter which one you do first, right, left, and main portal veins. Of course, they should be all of them. Hepatopedal towards the liver. You're not going to find, you're unlikely, I can't think of why you would find reversal of flow. That's, remember, hepatofugal, that occurs with portal hypertension. And it occurs when well, actually, I take that back, because hepatofugal flow, of course, occurs with portal hypertension. It oftentimes occurs because the liver is cirrhotic. What happens is blood comes in through the artery, hepatic arteries, and then out, rather than go through the arteries and into the hepatic veins, it comes out the portal veins. So you get backwards flow in the portal. A liver failure, an acute failure of a transplant could potentially cause, I'll have to look that one up. It can cause a much higher increase in resistivity, and therefore blood could travel backwards. So I guess it could happen. But in any case, definitely want to look for hepatopedal flow, steady flow. We don't want to find, I didn't write it down here. Let's see. Flow that looks something like that is good. This could be, these undulations could be respiratory variability. And you could have some degree of let's just draw another line. Well, okay. What I've tried to draw is respiration and cardiac. So the respiration are the longer movements, or the longer variability, And on top of that, you might be able to see some cardiac. I've got a picture in the PowerPoint where the website's called it normal, and I don't find it normal, but I'll show you that later. You don't want to find, of course, any kind of stenosis. You don't want to find thrombosis. Where it is. Okay. We check for stenosis. Generally not a very fast vessel. It is a vein after all. So if you find stenosis, that is of concern. Thrombosis is also a concern. Stenosis, let me go back to that. That could be at the anastomosis. So if you could see where the anastomosis is, or you think you know where that is, you look extra hard for any kind of stenosis right there. Or could it be just simply a kink? Things moved around after they sewed the patient up, things moved around a little bit, and the main portal vein kinked on itself and caused a stenosis. And then following that, possibly a thrombosis. And of course, that's right, left, and middle. So, and then with the arteries, again, right, left, and proper hepatic arteries. Left, if present. If we've only put in a half a liver, then you're not going to have everything, but you're going to have right and proper hepatic arteries. And when we look at here, we're going to want to find the resistive index. I'm sorry, I apparently forgot to not write this down. Resistive indexes that are too high, if it's too high, that could indicate I'm sorry. Rejection. So that the liver is rejecting the transplant. The thing though is, in the first 48 hours, I'm sorry, I gotta go looking for. In the first 48 hours, it is possible to have a waveform to look like that. That RI, that resistive index, is equal to 1.0. And that is O chi in first 48 hours. The reason for this is because the liver is swollen, or may be swollen, and that extra internal pressure is causing the blood flow to come down to 0 and end diastole. Beyond 48 hours, not good. And so over time, like over the first day perhaps, let me just erase a little bit here. Now we get maybe a little bit of flow to there. So that's still high resistance, but it's not 1.0. Now we're looking at oh, let's just take a guess at 0.9. That's better, still not good overall. That's not something you'd want in a normal liver, but this is still within the first, let's say, day and a half. And then a little more time goes by and everything's going well. Oh, that's right, this is on a different level. I can go ahead and erase as much as I want. Awesome. Well, that's not exactly how it looks, but now we're saying, let's do, now it's 0.7. Let's just say, remember that's measured peak systole minus n diastole divided by peak systole. So peak systolic velocity minus n diastolic velocity divided by peak systolic velocity. So once again, early on, an RI of 1 is okay. Normally, an RI of 1 in a liver is a really bad thing, but as long as it's a transient, temporary thing in the first 24 or 48 hours. Now, if you go and you find a resistance index that's too low, that is stenosis, or let's do, be a little more accurate, post-stenotic. Post-stenotic. Well, why? Because you guys know this one. A little cheater. Peak systole. No, I don't want it. Peak systole minus n diastole divided by peak systole. Now let's just say this RI is equal to 0.4. That is too low. That is a numerical indication of tardus parvus. And also when we measure impossible to draw. Sorry, I'm in the wrong. That's okay. The time frame, the acceleration time would also be increased on this as well. So this is post-stenotic waveform there. Thrombosis is also a problem with hepatic arteries. Normally not an arterial thing, thrombosis, but in this case, it can be. So since that's not it. Yeah, just had to double check. Most common vascular complication. Thrombosis is the most common vascular complication, not necessarily the most common complication overall, but vascular-wise. And then very close behind that is stenosis. I believe that's second most. I don't think your book says, but I think that's the second most common vascular issue. The anastomosis for this guy, remember, it could be to the proper hepatic, or the the proper hepatic. It could be gosh, they could really find any other artery in the area. They can go, if they had to, directly into the aorta. They can go into the side of the SMA or the celiac access. So be aware that the standard way of doing things is not always the way it's done. So after doing the hepatic arteries carefully, and of course you're measuring all the way through the artery. You do color Doppler. You look for any kind of aliasing on color Doppler. Nice. Look for color Doppler aliasing, and that preferentially is where you're going to put your spectral Doppler. Angle correct, of course, and then walk it through. Walk through. And always have your volume up, because like I've told you guys before, I can't tell you how many times I have heard a stenosis before I've found it, before I've actually seen it. Okay, hepatic veins, once again, right, middle, and left hepatic veins. These are below the baseline, or these other two are above the baseline because they're both hepatopedal. Hepatic veins is below the baseline. A normal hepatic vein, more or less like that. Actually, I like this last one best. That's very, hepatic veins normally are very back and forth because of the proximity to the aorta, to the heart. I'm sorry, I can see you out of the corner of my eye. I'm just going to put you off to the side there. Because of their proximity to the heart, the hepatic veins are normally like this. And we've also learned in the past that hepatic veins that do that, well, that's not good. That means the liver is stiff. Now, here's the thing. If the liver in the first 48 hours, 24 to 48 hours, is swollen, then it may look like this. So that's something to think about. In that first period, the liver is swollen with extra fluid. It's edematous, really, edema. Then it may have an adverse effect on the waveform. But after that time period where the liver starts to calm down, it's no longer edematous, then we should have that waveform. Okay. The last thing we're going to look at too is the IVC, of course, but that's really right after the hepatic veins. It too will have the, oh, that's horrible. Well, the IVC as well should have a waveform like that. Perhaps the IVC will have that and the liver won't, or the hepatic veins won't, because the IVC is not going to be affected by a swollen liver. We're not going to take a break because it's definitely going to be a short day, so let's just work through it. All right. Hepatic artery thrombosis, stenosis, pseudoaneurysms, portal vein thrombosis, stenosis, inferior vena cava thrombo. Well, yeah, of course, looking for it. Oof, what happened here? Thrombosis, or IVC thrombosis, or a kink leading to stenosis as well. And hepatic veins are, for the most part, thrombosis is what we're looking for. I knew I was just missing something right there. Let's see, portal vein thrombosis, stenosis, inferior vena cava thrombosis, stenosis, hepatic vein thrombosis, stenosis. Yeah, I suppose a hepatic vein can get a stenosis as well. And also biliary ischemia caused by hepatic artery stenosis. I've got that in the PowerPoint. Pseudoaneurysm, thrombosis. Pathology box 28.2. We're gonna go over all that in the PowerPoint, so I'm not too worried about that. Yeah. All right, let me pull this guy up. Okay, so the liver transplant. My nemesis here. Okay. So these pictures, this is what counts, right? This is what we do. First of all, notice the difference in the size of the portal vein. That's a normal size portal vein. That's a normal size hepatic artery. These guys can be really hard. Hepatic arteries can be hard to find simply, even though they're right there. They have the same color because they're both going in the same direction, and they're usually right sitting on top. They caught this one a little bit farther away, that's fine, but they're usually sitting right on top. They could actually be hard to find, even though they're right there. Let's see, this velocity is 55, it's great. End diastole is 14, which leaves a resistive index of 0.73. That's fine. Anything under 8 should be fine. That's a normal liver. And you could see, nice, fast, sharp peak, a little bit of a bounce back right here, and then end diastolic flow all the way through. So the resistive index is here to here divided by here. And for them, they don't have an AT, they have a delta T, but that's a delta, that's the acceleration time. 34 milliseconds, or 34 thousandths of a second it took to go from end diastole to peak systole. So that's a nice sharp upstroke, completely normal image of the, oh, they said right hepatic artery. Okay, that's why it's a little bit from the main portal vein. Normal portal. What did I look, Pete? This is embarrassing.
I had really high hopes coming into this class. I'm so disappointed.
You know, so did I, and I actually feel like I'm really dropping the ball, but you know what? It's all good. Orthotopic, I couldn't remember that word. Orthotopic liver, TX is for transplant. It's not transplant times 3 years, it's TX is transplant. So orthotopic liver transplant, 3 years. P, and then, oh, they hid something here. Interesting. post-operation, post-something. Don't know what they hid. That's weird. Normal portal. Well, sure. It's hepatopedal. Uh, they might want to scan. They might want to put their Doppler right here because there is definitely a little bit of aliasing. Might not be anything, but definitely a little bit of something. I don't like this. Is not respiratory variability unless this person is breathing really fast. And there's also, look at this. You can all, I bet the tech could actually hear this, all this fuzz on the top here. It's like, so there's definitely an abnormal amount of turbulence in this. There's always turbulence in the portal veins, so I'm not looking down here at the loss of window because there never really is a window in the portal vein. But this raggedy edge up here, that tells me that was turbulent flow. Honestly, after 3 years post-transplant, I do not like the undulations. Does this patient have congestive heart failure? So this person might have congestive heart failure on top of their liver failure. Congestive heart failure creates a high pressure in the right heart. High pressure is extended through the IVC, extended through the hepatic veins, all the way through to the portal veins, and then you end out getting back pressure from the heart. And so normal portal, but perhaps an abnormal heart. I'm not 100% sure, but I don't like the looks of that at all. This hepatic vein, this is great. Just a very, very slight change in direction, which is normal. So it's like backwards, backwards. That's great. This person has a normal heart as well, because if it were congestive heart failure, like I suspect this person was, then this would be exaggerated. Let's see, right hepatic vein. Yeah, I'm sure. By the way, this is a good place. This is right hepatic vein near the origin. I'm sorry, not the origin on a vein, near the distal, technically distal part of the vein, where it's just about ready to dump into the IVC. That's the best place to get this waveform. If you try to get that waveform on a hepatic vein all the way up here, you'd never do it. You'd never get this. It'd just be steady state. Nice, beautiful hepatic veins here, but necrosis due to hepatic artery thrombosis. So part of the liver has died on this patient. Bad news for them. Is this the same patient? Can't remember. I don't know if this is the same patient or no, but no flow in the hepatic arteriole. And I just wanted to rhyme. But it looks like they put on power Doppler, doing their best to image. And I don't know why you would use power Doppler here, but trying to find any evidence of flow in power Doppler can help you with that, but I think it creates more of a mess than it's worth. But in any case, they were not able to find flow in the hepatic artery at all. This is a post-stenotic. Not terribly, not like really gentle waves, but definitely if they had done a measurement, let's say from here to here, that acceleration time would definitely be longer. The resistive index is 0.4. That's too low. So that the number alone should alert the doctor. And there's also, it appears to be turbulent flow here. Although it's such a small artery, it's hard to know if that's turbulent flow or if it's just technical error beyond what you could do. But definitely the difference between peak systole and end diastole, the velocity difference is only 10, 11, just not very much. So that's why the resistive index is too low. Okay, for immediate post-op hepatic artery to have an RI of 1. Resistive index here is 1. You see where they put peak systole and end diastole? They put it on the baseline, which creates, well, they don't have an RI up here, but it is 1. In fact, they even slightly put it below the baseline, but that's just operator error. Same patient, same day, I think it was just kind of like the other end of the day, maybe morning, and this is night. We're starting to get some forward flow because this liver, which is, what? Look at it. Yeah, that's edematous. That's a pretty dark liver, or at least I think it is. And with more fluid inside of the liver parenchyma, it should become a little more hypoechoic, and I think it is. Hard to say without seeing the kidney. But at the end of the day, the same patient starts getting forward flow. That edema is going away. That liver is starting to repair itself already. And within a couple of days, this person's resistive index is going to be completely normal. Let's see, it's still, good. 0.85, that's still high, but it's getting better. So this patient's well on their way to recovery. C arrow, so here's just a beautiful CT reconstruction of a stenosis right here. This is just so cool. We have to take a moment. First of all, I have no idea what all these are. The guy's popping pills or something. Yeah, no idea what those are. But so stinking cool. If you really just stop and look at this, obviously aorta, celiac trunk. This is the seagull. We're seeing it from a really different direction, so it's hard for us to get, but here's the left wing of that seagull, and then it becomes tortuous, and it's going to kind of go around and go all the way to the spleen. So here's the spleen starting to fill in here. And oh, by the way, in order for them to do this image, this person had to have an injection of contrast agent. We are not seeing any vein. We're only seeing the arteries. So this contrast is in the arteries, and it's starting to fill the spleen. So that's why we're starting to see splenic tissue here. In any case, this is just a really cool, let's see, splenic, doing that. Nice little S curve. And that very often is a really tortuous artery. And then this guy is a little bit tortuous too, isn't it? It kind of went off in this direction before doubling back. So the common hepatic artery went the wrong direction, I think, before doubling back. Oh, here's liver. We're not even seeing the liver. The liver's not filled in at all. So we're not seeing the liver is coming across here because we have right and left hepatic arteries. Yeah, I think that's a hard one. As we go farther down, obviously the SMA comes down here. Right renal artery. Yeah, right. Right renal artery, so that's part of the kidney right here. The little segmental arteries coming off the right renal artery. Pretty stinking cool. Yeah, so I just thought that was cool. Patient here has a pseudoaneurysm. Not a great yin-yang picture by any means, but we definitely have flow inside of this. So doctor just hit an artery with the needle. It happens. Not their fault. Portal vein thrombosis. Main portal vein. But yeah, you can clearly see there's no flow here. Not 100% sure what flow this is. Looks like we have artery above it. Artery is tortuous, so you get an artery here and then an artery there. And then that artery is coming in. It's the same artery coming here, right over here, but it's slightly different angle, so it's kind of blue-red. Main portal vein helical flow is more common in transplants. So this could be a very confusing picture. I think we saw one video where the guy's, is like, oh, this happens all the time. No, it doesn't. This is very unusual for the main portal vein is tortuous. There can be some helical flow, but not so much so that you actually have forward and reverse flow in color. So this is super helical flow. In other words, the blood is just spinning all the way up into until it gets to the right and left branches. If you were to put your pulse wave over here, you would have hepatofugal flow. So it's important to understand where to put. You don't want to show that. Or at least you want to show that the flow is mainly going into the liver. Once again, that's an indication in a vein like this of really tortuous or turbulent flow. Another T word, turbulent flow. Main portal vein stenosis, 206 centimeters per second is definitely not normal, considering, well, I don't know, I have another one, but way, way too fast. Main portal vein aliasing. So here's a main portal vein, a little bit of swirling again, but not so bad this time. Huh. You might actually see a little bit of the right adrenal gland too. Maybe. Anyway, but this is where your eyes need to go when you see aliasing like that. This is reversal of flow here, remember. That's aliasing. Same patient, flow is 150, 151 centimeters per second right there. So there is a kink. And oh, note the ascites. A little bit of ascites up here. So that's something we definitely want to make sure the doctor is aware of. Sorry. Bud Chiari. So here's a nice thrombosed, looks like middle hepatic vein is completely thrombosed. So obviously that is bad news for that patient. They're waited all this time for a liver and it's not going to work. Hepatic vein stenosis. So, yep, a little bit of aliasing right here. And I'm sure they walked their way through this. In other words, they started here and they walked up and down until they found the highest stenosis, which I don't see a measurement for it, but it's probably 200 centimeters per second, which for a vein, again, is very high speed. And an IVC stenosis at anastomosis. So let's see. Velocity 2.63 meters per second, so 206 centimeters per second. Again, very fast for a vein. I don't know how they know for sure that's exactly what the anastomosis is. If that is, it's probably a piggyback anastomosis, right? Maybe. But, and once again, as we're going through, You know, there's aliasing up here in the hepatic vein. Is that because of, let's see, what is our, I can't see what our settings are at, but it could just be that our settings are too sensitive, or it could be that there's something going on there as well. Biliary necrosis due to hepatic artery thrombosis, I believe it was a hepatic artery thrombosis caused biliary necrosis. So the biliary system basically is dying or dead because it's not getting enough blood supply. Sloughed material, in other words, material that's shed off, or sometimes called casts. And I believe they're called casts, by the way, because like in the kidney, they talked about casts as well. Microscopically, they actually look like the structures they came from. It's like a cast of the structure it came from. Like when you guys who are looking for Bigfoot, they'll do a cast of the foot, you know, the impression. That's what they're talking about when they're talking about cast scenes. So, but that's a microscopic cast, and what we're seeing is sloughed off material becoming more echogenic. Oh no, that was the end. I think that's a record. All right, I don't like that because we've got so much to do. But here's the good news. It's good news if you're not a big fan of vascular. We're not going to be talking about too much vascular. And let me turn off the evidence receiver here.